Hi everybody, welcome to this video. In today's video I will be discussing multiple myeloma, which is a very interesting topic. It's very important for USMLE Step 1 and for your general medical knowledge. So I am going to go ahead and give kind of a zoomed out view of multiple myeloma and then zoom back in again so that you have a good solid understanding of how this disease works and what exactly it is doing to the body. So let's go ahead and get started here. I'm going to zoom in here and we're going to start off by talking about let me hide this here one second. We're going to start off by talking about the antibody structure itself. So as you most likely know, so it's formed with a light chain here as well as a heavy chain here. So this is your heavy chain over on this side, and then you can see your light chain over on the other side. The light chain is over here. So what this means is that there are different components that can contribute to plasma cell neoplasms. So when we think about multiple myeloma, it's important to recognize that it does exist in a spectrum of many different diseases. So these diseases are called plasma cell neoplasms. Why are they called this? Because there's a specific cell called the plasma cell, which is demonstrated here by this angry looking cell. And essentially these cells are the end product of B cell differentiation. And what they do is they produce the monoclonal immunoglobulins or immunoglobulin fragments. Normally in our bodies, the plasma cells are going to produce antibodies for us. In this case, the plasma cells are bad plasma cells, and what they're doing is again producing monoclonal immunoglobulin or immunoglobulin fragments. So this can result in excess light chains as well as complete immunoglobulins. So either or can happen. Oftentimes when we see light chains, they're in a proportion of kappa and lambda, but sometimes we can see this proportion out of balance. So when we have this abnormal immunoglobulin form in the body, we call this either a paraproteinemia or a monoclonal gammopathy. So you'll hear those terms as well. So here's just a quick scheme of how the maturation of B cells occurs. So you have your regular B cell here, which then gets activated, which then gets differentiated into either a plasma cell or a plasmablast. And so those cells are going to express certain types of markers, which you can find on flow cytometry. So we'll talk about the different plasma cell neoplasms briefly. The first one, of course, is multiple myeloma. So multiple myeloma is marked by tumors throughout the skeletal system. They're bony lesions. A plasmacytoma is a term you might also hear, and that is a single mass in bone or soft tissue versus multiple. And then also you may see something called smoldering myeloma. So this is a lack of symptoms and an increased M component. The next one you may hear is Waldenstrom macroglobulinemia. So remember for this one, this results in an increased immunoglobulin, and that one is going to be IgM. So this results in hyperviscosity of the blood, which is going to lead to a number of different pathological conditions. And Waldenstrom can be associated with lymphoplasmacytic lymphoma. That might be a little bit low yield, so you don't have to memorize that, but just important to be aware of. The next one here is heavy chain disease. So this is a rare monoclonal gammopathy, and this is when there is synthesis and secretion of free heavy chain fragments. So remember we talked about the antibody being a heavy chain and light chain. So in this case we're focusing on the heavy chain. Then we have primary immunocyte-associated amyloidosis. So this is when our light chains are being produced by the plasma cells, and they're usually lambda light chains, and these deposit as amyloid, causing all sorts of problems for the body. And this can be associated with multiple myeloma, or it can be a minor clonal population of plasma cells in the bone marrow. The last one is the most benign form, and that is MGUS. You don't see any symptoms in this population of patients, but they do have increased M components in the blood, and it can transform to multiple myeloma. So again, MGUS can transform into multiple myeloma. So it's important to kind of monitor these symptoms or monitor these patients to see if they are developing symptoms. So we're going to zoom back in here. And so when we think about multiple myeloma, especially particularly at the USMLE level, the favorite thing that everybody likes to learn is the CRAB mnemonic. So I spent a long time drawing this CRAB, so I hope you appreciate it. Anyway, so the first letter stands for hypercalcemia. So we have increased calcium levels in the blood. And then the next one is going to, and this is secondary to bone resorption. So because the bone is breaking down, it's releasing calcium into the bloodstream, which of course is going to cause all kinds of problems. The next one is going to be renal dysfunction. So renal dysfunction. And then after that, we have anemia. So of course, if the kidneys aren't working, we're not going to produce EPO, and then that can lead to anemia. And the last part here is bony lytic lesions. And this is very high yield and important to remember, these bony lytic lesions, which can be seen on radiography. So the last thing here is that we're going to kind of talk about different things that you should be aware of when you think about multiple myeloma. So there are two important markers for these types of tumors to be aware of. One is CD138 and the other is CD56. So if you check these on flow cytometry, they may light up positive in these situations. The next one is you want to think about the morphology of the disease. Where does it happen? It happens commonly in the vertebral column, ribs, skull, pelvis, femur and clavicle, amongst other places. And the bone marrow is going to have roughly greater than 30% plasma cells. So there have to be increased number of plasma cells. And when you look at the bone marrow, it's going to have cells such as plasmablasts, Mott cells, and Russell bodies, and Dutcher bodies. So these are, or Dutcher bodies, sorry, I don't know how to say it. So these are all going to be different things that you're going to see in the bone marrow when you're looking at it under the microscope. The other thing is that you may look at the peripheral blood and notice a rouleau formation. Also high yield to be aware of that fact. So in general, if the tumor cells have got into the peripheral blood, then this is now called a plasma cell leukemia, and that is a very dangerous thing. And so we'll take a look here at some of these terms. So a plasmablast is going to have prominent nucleoli, fine non-granular chromatin. It's going to be large. There's going to be some perinuclear clearing, blue cytoplasm, and eccentric nucleus as well. And you can see these little kind of prominent nuclei as well. Mott cells have these, weird vacuoles here. So that is something you can also visualize on bone marrow. And then, of course, here's your rouleau formation with that stacking of the red blood cells in the peripheral blood smear. And here, of course, are the lytic lesions that are very important to be aware of. They usually make it pretty obvious on tests if the patient does have lytic lesions. And last chart here is the one with the gamma spike here. So this is what the M spike is referring to. It's referring to this gamma layer or area here in this curve. So once you see this, that means that there is a potential monoclonal population in the bloodstream. And then lastly, we have clinical features. So clinical features, again, remember there are bony lesions leading to resorption, leading to increased calcium, and that's going to cause confusion, constipation, and renal issues. Increased light chains can cause renal damage, and it can also lead to the AL subtype of amyloidosis. So again, when you look at the SPEP, you're going to see a monoclonal spike due to the monoclonal immunoglobulin. IgE is the most common form, followed by IgA, but you can also more rarely see IgM, D, and E. And so when you think about the genetics, remember that these are associated with cyclin D translocations, as well as 13q and 17p deletions, and translocation of 4 and 14, but do remember that this is associated with a poorer prognosis than the cyclin D translocations. And then lastly, there are treatment options available. One treatment option is lenalidomide. I don't know if I'm pronouncing that correctly. So sorry, I'm not an oncologist. Anyway, so that is the treatment, as well as bisphosphonates, of course. And yeah, that's all that I have today on multiple myeloma. So I hope that that was an interesting and riveting discussion for you. If you have any questions, feel free to let me know, and I am happy to hear from you whenever. Thank you. Have a great day. Bye.